Welcome to EADV Live. Today's topic, Stevens-Johnson syndrome and toxic epidermal necrolysis. I'm Christopher Horskamp, and on behalf of the EADV, we welcome you to today's interactive webcast. If you have any questions or comments about the subject matter, send them in at any time during the presentation, and our presenter will do his best to address them at the end. Today, we are joined by Speaker Associate Professor Hao-Ya Lee and the EADV Education Committee member, Dr. Sarah Walsh. Dr. Walsh, I hand it over to you.
Thank you very much, Christopher, and welcome everybody. Thank you for joining our broadcast today. As Chris mentioned, my name is Sarah Walsh. I'm a dermatology consultant in London, and it is a huge pleasure to be able to introduce a colleague and a great friend, someone who I worked with in London a number of years ago, Dr. H.Y. Lee, now Associate Professor and Head of Department of Dermatology at Singapore General Hospital, where he is also the director of the Allergy Centre. Dr. Lee is an excellent clinician with huge expertise in the management of severe cutaneous adverse reactions. And I had the pleasure of seeing just how good he was in this area when I worked with him here at King's. He's very widely published in the area and is very generous with his knowledge, authoring numerous book chapters and speaking internationally on the topic. And he's currently also the president of the Dermatological Society of Singapore. I was really delighted when he accepted our invitation on the part of the EADV School Committee to speak to us today in this webinar on the topic of SJS-TEN. And I'm really looking forward to hearing his talk. Over to you, HY.
Thank you, Sarah, very much. That was very kind. And I'd like to first thank the Academy for the invitation. It's both a privilege and honor. So these are my conflicts of interest. In dermatology, we don't deal very much with life-threatening diseases, but among the handful of diseases that we deal with, perhaps the most severe would be Stevens-Johnson syndrome and TEN. More than 25% of patients would die from the disease acutely, and more than 60% of survivors will struggle with long-term consequences. And this afternoon, this would be the scope of my talk. I would share some of the advances that we have made in SJS-TEN, some of the pitfalls and challenges, as well as future opportunities. So the first advance, and I think this is really fundamental, is in the area of clinical classification. This has really allowed us to understand the disease, conduct clinical studies, as well as evaluate therapeutics in this area. As dermatologists, we are very well aware that Stevens-Johnson syndrome and TEN exists as a disease continuum. If the body surface area is less than 10%, it's SJS, and if it's greater than 30%, it's TEN, and in between, we have the overlap. Mortality also increases as the BSA increases, and this ranges from about 12% in Stevens-Johnson syndrome to about 50% in TEN. Similarly, as your disease detachment worsens, you're at higher risk of sepsis, metabolic and fluid complications, organ involvement, and death. So although this classification is widely known and widely accepted, this hasn't always been the case. There was a period of great confusion when all these four diseases, erythema multiforme minor, EM major, SJS, and TEN, were all lumped together. Von Hebra was credited with describing erythema multiforme minor, and it was also noticed that there were cases of EM with oral mucositis, and these cases were termed as EM major. In 1922, two pediatricians, Stevens and Johnson, described mucocutaneous reaction with severe mucositis, conjunctivitis, and acute skin eruption, and this was known as SJS. At that time, it was thought that EM major resembled SJS, and the terms were used loosely, interchangeably. And at that time, Both terms were used widely, and in 1956, Lyell described TEN, or Lyell syndrome, although we now know that out of the 4 cases, 2 of them were probably not TEN. However, it was also evident that there were cases of SJS that progressed to TEN, and as a result, all of these 4 diseases were lumped together. This was a great impediment to clinical research and epidemiology, and this confusion was there for quite a while. It persisted until a group of investigators reviewed hundreds of photographs and classified these cases into TEN, SJS, and EM. And the basis of classification was based on the body surface area detached, as well as the patterns of individual lesions. Key to the patterns of individual lesions was the target lesions. If you had typical targets, you had EM major. If you had atypical target and your BSA is less than 10%, you had a SJS. And if you had atypical targets and your BSA was more than 30%, then you would have TEN. These pictures shows how similar the 2 diseases can look like to the untrained eye. On the left column, we have a picture showing EM major. And if you scrutinize these target lesions, you will realize that there are 3 zones. It's regular, there's a well-defined border, it's palpable, and they tend to be distributed in an acral distribution. On the other hand, in SJS TEN, these targets are poorly defined. They only have 2 zones. They are typically non-palpable. They are associated with blisters and erosions, and they tend to start from the head and neck and truncally, at least initially. And this classification was further validated in the SCAR study when they showed that EM and SJS and TN indeed had very distinct patterns. EM patients were younger, they tended to be male, and they were also associated with recurrence. And this was in distinction to SJS and TN, where they tended to be older. There was a higher proportion of mortality. And in addition, when we consider the etiology of these diseases, we could see 2 clear patterns. In the EM group, they were more associated with herpes and infection, whereas in the SJS overlap and TN group, they were largely due to medications. And that really clarified the clinical presentation and the etiology of these 2 diverse group of diseases. And that brings me to the second advance, and that is causality, drug causality. Through various epidemiological studies by the SCAR, EuroSCAR, and the REGISCAR studies, we now know that although a variety of medications have been reported to cause SJS and TEN, the majority of these reactions are due to just a handful of medications. These are your allopurinol, infective sulfonamides, the anti-epileptic medications, Oxycontin, NSAIDs, and nevirapine. These have also been shown to be the major culprits in other parts of the world, and we now know that these high-risk drugs are the same globally. Most of these drugs are taken 2 to 8 weeks prior to the onset of the reaction. What came out of these studies on drug causality was also this interesting observation. Although globally, we all shared a similar group of high-risk drug, there were some variations. So if we look at the column on the right, the proportion of cases that were due to allopurinol was fairly similar. However, if we look at carbamazepine, it was very different. Carbamazepine accounted for 4 to 8% of cases in Europe, whereas in the Far East, it would account for 20 to 30% of cases. And this was despite, differences in prescription patterns and practices. So this was the first time that there were some suggestions that this disease could have some ethnic or geographic variation. And indeed, our colleagues from Taiwan published this landmark study in 2004, where they showed that indeed there was a genetic marker, and this marker was B1502. And if you were Han Chinese and you carried this marker, your odds ratio of developing SGSTN was the magnitude of more than 2,500 times. And this leads me to the third advance, which is in the area of pharmacogenetics and disease mechanisms. So in addition to carbamazepine, there were also HLA identified for allopurinol. And unlike carbamazepine, you would see that this allele was found and is also a risk factor in a diverse ethnic groups, whether you're Chinese or European. And this may also explain why the distribution of cases that were attributed to allopurinol was similar globally. Since then, there have been several more drugs and HLA associations that have been published. And what is important to recognize is that these HLA and drug associations are drug, phenotype, and ethnic specific. It means that if you had B1502, it means that your risk is increased only for SGSTN that is due to carbamazepine, and it's only a relevant risk factor if you're a Han Chinese. This is not found in Northern Europeans. In Northern Europeans, we have another genetic marker, and that will be A3101, and that is a risk marker for both DRESS and SGSTN. So aside from the data on genetic markers, there have also been significant progress that we have made in understanding how the disease works. And if we take the model of allopurinol, so we now know that there are clinical risk factors for the development of allopurinol SGSTN. These include elderly, poor renal function, increased dosage. And when those clinical factors are present, this results in high plasma oxypurinol levels. And in the right patient who carries the right HLA, the drug gets presented to TCR, which are your T cell receptors. The drug-specific T cells are activated, and this leads to the release of soluble mediators, of which granulysin is probably the most important. This then leads to the widespread keratinocyte necrolysis. So, in addition to being a genetic marker and helping us to understand the pathogenesis, the pharmacogenetics have also led to clinical implementations and drives to prevent this disease. Following the discovery of HLA-15-2 and carbamazepine SGSTN, the FDA has issued advisory that genetic testing must be performed prior to prescription in Asian Americans. And similarly, in parts of Asia, Taiwan, Thailand, Singapore, and Hong Kong, we have now made 1502 screening prior to drug prescription mandatory, and this has led to a reduction of carbamazepine SGSTN in Singapore by 90%. So I hope that in the initial few slides, I have shown you all that, with the advances in clinical classification, causality, and pathomechanisms, what was once considered idiosyncratic, unpredictable, unpreventable, is no longer so in 2021. Right. For the next part of the talk, I would just like to switch gears and to consider, apart from the advances that we have made in understanding and managing this disease, what are some of the pitfalls and challenges that befall us? Many of these pitfalls arise due to an underappreciation of the natural history of SJS-TEN, and I thought that it's important for us to review this natural history. So typically, a high-risk drug is taken 2 weeks to 2 months prior to the onset of symptoms. The first symptoms of the disease are prodromal. They are flu-like in nature. The patient might have a fever, cough, sore throat, conjunctivitis, and then the rash starts. It starts to blister, and over the next 7 to 9 days, the disease increases in extent, and then it miraculously stops. The disease arrests, and then starts to reepithelize. There's this time period from the onset of blistering to reepithelization. That's the time when the patient is at risk of acute complications, and this is due to the impaired skin barrier or skin failure. These series of photographs shows the progression of SJS-TEN. The first picture is a patient who presents on day 2. Just by looking at it, you may think that this is a exanthematous drug eruption, but over the course of 24-48 hours, the blisters starts to be noticed. There are sheet-like detachment. The skin is detachable. Nikolsky sign is positive. By day 8, some of the erosions are healing. There are areas of post-inflammatory hyperpigmentation. And by day 14, reepithelization was complete in this patient. So I would like to first start with the first challenge, and that is in the area of causality. Although we know that the majority of SJS and TEN are drug-related, there's always been evident that there was a small proportion of cases where no clear drug could be identified. These were patients who were not on any drugs, or they were on drugs that they have taken for years. And basing on the Euroscar and Regiscar data from Europe, it was shown that 15% of cases are unlikely to be related to drugs. And similar findings were found in the United States, where 10% of cases were not drug-related. The causes of these non-drug cases are not clear. In our center, we routinely send mycoplasma, and I think similar experience have been shown in the French Reference Center, where mycoplasma can at best only explain 10% of all these idiopathic cases. Another challenge with causality is the issue of protopathic bias. And protopathic bias arises when we blame the drug that was used to treat the symptoms of the disease as the causative drug for the reaction. And how may that occur? So remember that the initial symptoms of SJS-TEN are the cold and flu-like symptoms. A patient may be prescribed flu medications, antibiotics, or analgesia. And over the course of 24-48 hours, the rash develops, the blistering starts, and then to the unfamiliar physician, he may inadvertently blame these co-medication as the trigger for the reaction. And this is probably even compounded even more in idiopathic cases, because in such cases, you are unable to identify a high-risk drug. And this is still a big problem because there are cases and studies that continue to attribute co-medications as triggers of SJS-TEN. And this was a recent study from JAMA Ophthalmology in 2017. And you can see that in their series of SJS patients with ocular involvement, more than 50% of patients were attributed to, or their reactions were attributed to co-medications. So how then do we avoid these issues in causality? The registrar group has come up with an algorithm, and this is termed the Alden score. This is a composite score that looks into various factors such as latency, the presence of a drug in the body at the point of reaction, the notoriety, the effects of challenge, either pre-challenge, re-challenge, or de-challenge, and other causes, particularly if there was a single high-risk drug that was identified. So what should we do if we can't find any strong drug association? What our center do, and I'm sure many centers out there do the same thing. We would ask the patient if there were any other occult drug exposure. And certainly in the Far East, we would like to take a history of complementary health medications. And there have been many reports of these medications being adulterated with NSAIDs. We would also run the mycoplasma studies, do an anti-nuclear antibody to exclude the possibility of SJS/TEN-like acute lupus. In all our patients gets a biopsy with direct immunofluorescence. I would like to now then move on to the second challenge, and that is the question, what is the prognosis of SJS/TEN? For the last 20 years or so, all of us have relied on SCORE10. SCORE10 is a score that is made up of 7 clinical and biochemical factors, and depending on the number of factors that the patient had, we are able to predict a mortality risk from 3% to 90%. The SCORE10 was again validated at the French Reference Center. The developmental cohort was from 1979 to 1993, and the validation cohort was 1994 to 1998. SCORE10 has been externally validated, and because it has been validated, it is also used as an internal control to evaluate the efficacy of treatment. And how do we do that? So supposing we had a cohort of SJS/TEN patients, and with their SCORE10 values, we are able to predict the number of mortality that will occur in this cohort. And if we treat them with a certain intervention, we would then compare the observed mortality versus what was expected from SCORE10, and then we might come to a conclusion if the treatment was effective or not. In addition to that, SCORE10 has also been used as a benchmark for individual centers for us to audit our practice to see if our observed mortality approximates that of the expected from SCORE10. Despite its external and internal validation, there have been some concerns that SCORE10 might have deteriorated with time. As over time, we would have expected that ICU and supportive care would have improved. There were also considerations that the lung involvement, which was a strong mortality factor, was not directly factored into these 7 variables. More recently, our colleagues in the US developed this new scoring criteria, the ABCD10, and this looks at 5 factors, and cancer and dialysis had 2 and 3 points, whereas the rest of the factors were 1 point each. And depending on the number of points that you had, your mortality risk was estimated between 2.3 to 83.6%. We were interested in evaluating both scores and to determine what was the better prognostic marker for our patients. And we have shown that SCORE10 was indeed superior to ABCD10 in mortality prognostication, its calibration was superior. And so if you needed to use a score to calculate prognosis, score 10 would be a better score. However, what we have also demonstrated was that score 10 demonstrated time-associated deterioration of calibration. And this was exactly what many have suspected, that over time, score 10 has overestimated mortality. So there are several implications on this. One, we are probably overestimating death, and in our prognosis discussions with patients, we are probably overestimating mortality. Secondly, there's also the impact of treatment. So we may be coming to the conclusion that certain treatments are more effective when this efficacy, it's not due to treatment itself, but rather due to the overestimation of mortality in score 10. And this brings me to the next challenge, and that's what is the ideal treatment for SGS-TEN? This is probably the most controversial topic in dermatology, and in summary, I don't think globally we have a consensus. So this was data that was from after a survey from the World Severe Cutaneous Adverse Reactions meeting in 2013, as well as interviewing physicians in North America. And you can see that there's really a diverse opinion on what is the ideal treatment for SGS-TEN. However, at this time, I think it's important for us to take a step back. And I think what Alan Lyell published in 1967 in this review paper, it's still very relevant today. And I quote, "The effects of treatment are difficult to judge in a syndrome which has a strong natural tendency towards resolution, as well as a high mortality. It is easy to attribute an apparently miraculous escape from death to the effects of vigorous steroid treatment, whereas one may be merely observing the natural course of events. And in this age, we could replace steroids with cyclosporin, IVIG, anti-TNF, but I think this statement still holds true. So let us go back to the natural history of SGS-TEN. So the progression of disease lasts from 7 to 9 days, and this is really the short therapeutic window that we have in impacting disease. So if we gave an intervention at time point A and the disease continued to progress, we may come to the conclusion that intervention A is not useful, it didn't arrest the disease, and then we switch to intervention B. By this time, the patient is at the tail end of the progression, and within 24 hours, the disease arrests. Although this is more likely the natural history of SGS-TEN, to some, they might erroneously attribute this arrest of disease to the therapeutic effects of intervention B. So I think this is one of the pitfalls that we need to be aware of. So what does the evidence then tell us about the best treatment for SGS-TEN? There have been numerous trials and studies, or there have been numerous studies that have been done on intervention in SGS-TEN, but we only have 2 trials. One was a negative trial by the French reference group again, and in that study, they showed that thalidomide was deleterious, and the trial was stopped early. A second trial was carried out by our Taiwanese colleagues, and that trial compared anti-TNF versus corticosteroids. Although the mortality was slightly lower in anti-TNF, this was not significant. And if we looked at both the observed versus expected score 10 mortality, both steroids and etanercept showed an improvement in the mortality. How about systematic reviews and meta-analysis? There have been 3 recent systematic reviews, and the one by Zimmerman, they concluded that corticosteroids and cyclosporin may be helpful. Both Tsai and Torres and Navarro showed that no treatment was effective to reduce mortality rates, but when we considered standardized mortality ratio, cyclosporin and steroids and plus IVIG might be helpful. But before we come to a conclusion on that systematic review, perhaps I'd like to just show some trends that have been seen in various reference centers. These shows the temporal trends in mortality across Japan, France, Taiwan, and also in Singapore. And we showed that over time, there was an improving trend in mortality. And this was despite all of us using different treatments. And I guess what this shows is that these individual interventions are unlikely to be the only reason why mortality has improved over time. And I think we really need to consider supportive care and how improvement in supportive care has really led to better outcomes. So I think before we leave this part on interventions, I think it's important for all of us to be aware of the new bias in the evaluation of efficacy. Remember that over time, patients do better. So it's an unfair comparison when compared with historical controls. 2, we have shown that there is an overestimation of mortality over time if we use score 10, and therefore there may be a bias in attributing the efficacy of certain interventions. And lastly, when we look at endpoints such as disease arrest or wound healing, it's important to view them in the context of the natural history of the disease. And when we compare them with the effects of steroids as a treatment, remember that steroids sometimes can impede wound healing, and that does not mean that the other arm is better at wound healing. So I think that's the reason why both the French guidelines and the UK guidelines in 2018 and 2016 respectively came up with the conclusion that it is not possible for us to recommend for or against any interventions. So that's that for specific therapy. And although, we don't have a firm conclusion on specific therapy, there are many other factors that influence mortality in SJS/TEN. And I think a lot of our energy and efforts have been focused purely on specific therapies, but there are many other factors such as early access to burns and reference centers, early drug withdrawal, and supportive care that we need to focus on. So this is back to my favorite diagram again. This is the natural history. And this shows that even if we had an effective intervention that reduced the severity of disease, shortened the disease, there would still be a significant proportion of time where the skin would be in skin failure, and therefore it's really important for us to get such patients to a reference center and to optimize supportive care in order to improve outcomes. So what are best practices in supportive care? And it's advocated that these patients should be managed in specialized units or reference centers. The French group has shown us that the mortality is reduced in centers where there are high volume of cases. And similarly, we have recently shown that if your admission is delayed by 5 days to a reference center, your odds of mortality increases by 3-fold. So what are some of the things that we do in a reference center? These patients are nursed in specialized units. In Singapore, we have a very unique hybrid model where us dermatologists go into the burn center to manage such patients. It is also multidisciplinary. The ophthalmologists, the ICU physicians also come in. Other factors like sepsis management is optimized. Attention is paid to nutrition, fluid, organ support, analgesia, as well as the correct identification and withdrawal of the drug. I would just like to elaborate a little bit on how we can improve supportive care. And there are a few areas, and the first area is in the area of sepsis management. We know that 30 up to 50% of patients with SJS/TEN will become bacteremic, and patients with bacteremia are more likely to die and require ICU stay. The current practice is that no prophylactic antibiotic should be started, as this leads to resistance and nosocomial infections, but antibiotics should be initiated early when needed. However, it's easier said than done because there are important questions that we need to answer. Who will develop bacteremia or sepsis, and how can we tell when they develop sepsis? Because in many of these patients with that systemic inflammatory response, fever is often, or raised inflammatory markers are often not a good marker for infection. So we evaluated these risk factors and identified the following as risk factors for bacteremia: body surface area of more than 10%, anemia, and the presence of cardiovascular comorbidities. And at the same time, we would draw blood cultures regularly from these patients. In our center, we do it every other day. And on the day that the patient had a PET specimen with increased procalcitonin or is hypothermic, we know that it's a high likelihood that the blood cultures would come back positive, and that is when we would initiate antibiotics based on the prevailing microbiological milieu in the ICU. The other aspect to focus on is the issue of pulmonary involvement. This is often not recognized by dermatologists or other physicians that are not frequently managing such patients. And about a quarter of such patients would have lung involvement. Some of these are specific findings, such as bronchial epithelial erosions, whereas in others, they may have non-specific findings like pneumonitis and pulmonary edema. However, pulmonary involvement, it's a poor prognostic factor, and if patients have respiratory involvement, it's important to get them down to the ICU, get your intensivists on board. Sometimes they need to be intubated and supported early. And the last bit about supportive care is the issue of wound strategies. To date, this is a gap in our management of SJS/TEN. There has been no comparative studies between conservative treatment, where the detached skin is left in situ, or in surgical debridement, where particularly in the American burn centers, where there is operative debridement and a secondary application of allografts or other dressings such as BioBrain. In addition, there's also no evidence to show us what is the ideal wound dressing. Nonetheless, in our center, we do not actively debride these patients, and I hope these pictures would also convince you that if we left the detached epidermis intact as a biological dressing, we might reduce the incidence of post-inflammatory hypopigmentation as well. Finally, the last challenge that I would like to share this afternoon, it's really about recognizing the long-term burden of SJS and TEN. For a long time, we were always focused on treating the patient acutely, ensuring the survival. However, there is now perhaps a changing disease model where, in addition to the acute management, we would also need to manage the chronic sequelae that has been increasingly published in SJS survivors. The bulk of these chronic sequelae are the mucocutaneous and the ocular sequelae, but it's also increasingly recognized that many of these patients struggle with their activities of daily living, as well as psychological burden. And there have also been anecdotal reports of internal organ involvement, such as vanishing bile ducts, chronic glomerulonephritis, obstructive lung diseases as well. So chronic eye sequelae is really one of the most debilitating complications. It affects 30 to 80% of survivors, and 5 to 10% of survivors will lose their vision, and about half of them would have difficulties in activities of daily living. Now, the only predictor of chronic eye sequelae is the severity of acute ophthalmic involvement, and that's the reason why it's very important during the acute phase of the disease. We need to engage our ophthalmologist colleagues in our center. We have a very good relationship with them, and they are always actively reviewing these patients and performing amniotic membrane transplant, which seems to be associated with better outcomes, at least in the eye literature. These are some of the pictures of the chronic changes, and these are usually very difficult to treat and associated with very poor outcomes. These are some of the skin sequelae, keloidal scarring, post-inflammatory dyspigmentation, eruptive nevi. The mucosal surfaces can also be affected. The picture on the left shows a buccal chronic ulcers. There are also strictures on the angle of the mouth. In the middle picture, there's depapillation of the tongue, and patients with this often complain of a loss of taste. And finally, in the genitalia, it's important to get them reviewed daily to avoid complications of introital adhesions. Nails are also commonly affected. Up to 70% of survivors have nail changes, and there is suggestion that acutely, if patients have a periungual blister, this may predict severe long-term changes, and this is probably due to the fact that these blisters are probably a marker of severe damage to the matrix. Lastly, we know that many of these survivors struggle a lot with psychological burdens, and 30 to 60% of them would have some form of post-traumatic stress disorder. It affects their life. 30% of them remains unemployed after the acute event. 70% were afraid of subsequent medication exposure. And recently, our French colleagues have shown that about a third of survivors also complain of chronic pain syndromes. So I would just like to end this afternoon's webinar by just focusing on some of the opportunities that lies before all of us as dermatologists. I think there are opportunities in all of us banding together and carrying out that multi-centered RCT. In time to come, as we understand the pathogenesis of SJS/TEN, perhaps therapies like the antigranulysin might become a reality. We need to have studies to evaluate optimal wound strategies. we need to evaluate supportive care and to determine what's the best evidence of care. We need to refine our prognostic scores because this forms the basis of prognostication, and these are I guess a surrogate for us to evaluate treatment. We probably need to think of SGST as chronic disease. We need to recognize, prevent, and treat such sequelae, and to also evaluate what is their impact on QOL, quality of life, and how it influences their health behaviors. Lastly, I think the idiopathic group of SGSTN, really it's a interesting subgroup of patients, and it's also immensely distressing for patients who are unable to identify their triggers, and they are always concerned about the risk of a relapse of this condition. And I think it's important for us to further the science in that area. And finally, I would like to end by remembering Professor Jean-Claude Rougeot. He was really a giant in this field of severe cutaneous adverse reaction. He was a scientist and a clinician par excellence. And Rob Stern in JID 2017 has written this. It should be noted that Jean-Claude Rougeot's ideas and contributions are evident in much of the most important work done in this area of inquiry over the last 30 years. And I think this afternoon I have really shared how he has contributed to our field. And with that, I'd like to thank you all for tuning in. Thanks.
Thank you very much, HY. That was absolutely masterful, concise, clear, beautifully illustrated. Absolutely all that I expected it would be. And thank you so much for taking the time to speak to us today. And I should also say that I think Jean-Claude would be so thrilled with how you're using his legacy to improve care in this area, because I know you worked with him for some time and he was very, very fond of you. Now, it goes without saying that both thanks and questions are flooding in. And I promised you at the beginning of this, I promised you difficult questions, HY. So I'm going to start with one difficult question, a version of which was sent in by several people. What do you do yourself in your centre in terms of immediate care when you get a new admission with SJSTEN?
Right. So in addition to supportive care, my first sort of a treatment that I would use would be cyclosporin. We started off with 3 milligrams per kg, but now we are moving it up to 4 or 5 milligrams per kg over a shorter period of time. I know the initial French experience was tapered over a month, but we have sort of shortened that to 14 days. In patients with acute renal failure, which is fairly common in such patients, then sometimes we would use anti-TNF. In this case, would be etanercept.
And does your decision as to whether or not to use a systemic agent vary according to when you receive the patient in their journey? So I'm taking, for example, the contrast between receiving patient at maybe 2 or 3 days post the index lesion versus maybe 7 days post the index lesion, where they're a little bit more advanced in their disease?
Yeah. So I think typically, if it's post 7 days from the onset of disease, we will not give any active intervention.
Fine. So that is key. So there's a question from Dr. Rugova asking if oral ulceration is in any way predictive of airway or lung involvement.
There is some suggestion, but I don't think we are very clear. And the reason for that is because we haven't been actively, doing bronchoscopy on all patients with SGST. And although, one may come to a conclusion that, it's a continuous tract of cells, so, it would be possible.
instinctive to think it might be. Yes, yeah. I think there was that one paper that showed that tachypnea and increased secretions were clues to the presence of bronchial involvement, but I think it's an area that we still have more to learn about. I've had a question here. Do antihistamines play a role in the management of SJS-TEN?
I don't use any of that because I think itch is not a predominant complaint. Most of them complain of immense pain, and we try to control that.
Mm-hmm. And you referenced the recent work of Professor Le Fauché at the Créteil Centre regarding skin pain as a consequence of SJS-TEN. And for any of our listeners who haven't tuned in yet, one of the most recent episodes of the Dermatology podcast, I was lucky enough to speak to Professor Le Fauché and another colleague, Dr. Pauline Riley, on this theme of SJS-TEN and specifically long-term sequelae, which I'd advocate to those watching today. But I mean, management of pain in the acute phase is something different, and I think is quite challenging. What's your approach to management of pain in the acute phase, HRV?
So acutely, what we do, we sometimes get the anesthetist or the pain specialist in, and if the patients are lucid enough, we have them all on patient-controlled analgesia, and that kind of helps them to titrate the pain. But having said that, I think the greatest pain that is felt is often during wound change or when we look at the wound, and often before a wound change would probably give them a dose of opioids just to help with that. Mm-hmm. But it's important for us to monitor the pain, and we try to keep a pain score of less than 2 for all our patients.
Mm-hmm. Do you use ketamine or benzodiazepines at all in that mix, or is it usually opiate based?
Yeah, mainly opiate based. Yeah.
Mm-hmm. Mm-hmm. We've quite good experience here of using, as I say, syringe drivers containing some opiate, benzodiazepine, and in severe cases ketamine, and we find that quite effective. And I think the interesting thing about the management of the pain in the acute phase is that possible relationship with the development of PTSD and post-traumatic stress disorder, which you alluded to there, which again I think is an area that we have a lot to think about. And referring back to that podcast, I was lucky enough to speak to Dr. Pauline O'Reilly, who works in the University of Limerick, who's done some studies on this. Do you have any strategies in your own department for trying to mitigate the risk of development of PTSD, early intervention strategies or the like?
So I think it's important for these patients that once they are out of their acute phase or when they are re-epithelialized, we often get a medical social worker or psychologist just to do a baseline screening or just to speak to them and to identify if they are at risk for PTSD. But having said that, it's also been some of our observations that, we can't predict who would get PTSDs. And some of these would only come in months and down the road where patients complain of unexplained anxiety and depression.
Mm-hmm. Yeah. Mm-hmm. The interesting thing about Dr. O'Reilly's work was she also looked at the impact not only on the index case, so the patient, but also on the people around, so the family members. And I wonder if you had any comment on that, on the importance of, I guess, communication with the first degree relatives, and I guess your observation of what the impact of that acute disease on those around the patient, what those effects are.
No, we haven't looked at that, but I think that is a blind spot, and I think that's perhaps something that we should look further. How it's like we always think about how AD affects the whole family, and perhaps survivors in SJS-TEN, perhaps the whole family is affected in various ways.
Well, of course, you and I have a publication together, don't we, looking at the psychological consequences of DRESS, one of the other severe cutaneous adverse reactions, which did show amongst the first degree relatives that they developed a degree of trepidation about medicines, new medications. So I think it would be intuitive to think there might be a ripple effect in SJS-TEN of a similar nature. I mean, the other thing I was very interested in, you showed beautifully all that the mortality data and how mortality is going down over time, and we're not entirely sure precisely what that is due to, but it seems certain that it's not all due to systemic therapy. And I wondered if you had any thoughts on, clearly there is an important role in getting the patient to the correct site of care as early as possible in the disease course. And for that to happen, it requires primary care physicians and the untrained eye. You spoke about trained eyes and untrained eyes. The untrained eyes of the general physician in recognizing the condition. And do you think we do enough as dermatologists to ensure that the non-specialists have the tools to recognize this disease in its earliest stage, which we know can be difficult?
Yeah, you know, it is a constant challenge because at one point we were interested in finding out what were the misdiagnoses and the reasons for misdiagnosis. And, you know, many of these patients, you know, they go to GPs, they go to the A&E, they were treated as varicella, they were sent back, you know, so it's difficult. So I think a lot of it got to do with education, starting from medical school, telling them, you know, identify what are the red flags. You know, you really need to sit up and worry when a patient comes to you and complains that the skin is painful. So I think it's these things that we need to emphasize to medical students. Yeah,
and I do think that we as dermatologists have a duty to try and promote that education by accepting speaking invitations where we're likely to be able to influence people's knowledge. I do feel quite strongly about that. I've had a question about mucosal care, so care of the mucous membranes. I guess I know you've spoken about the eyes and amniotic membrane, so could I perhaps ask you to concentrate on the mouth, the nose, and the genital area, just in terms of what mucosal care you do in your centre?
Okay, so what we would do, you know, we would use a oral rinse. We would use a topical steroids ointment on the lips. We would examine the genitalia every day. You know, just to part the mucosal. If there are any adhesions, then we will try to separate them. You know, to use the paraffin gauze just to separate and just to ensure that these adhesions don't develop into strictures.
Mm-hmm. And routine catheterization, urine recatheterization, is that something you?
Yeah, so I think we tend to do that just because it makes the wound care a lot easier, and it also helps us to monitor with the fluids.
Yeah. And question here, which is rather broad, so just I suppose a short comment. Pediatric SJS/TEN, do you manage that at your centre as well? And what are the differences in the strategies you use for management?
I don't treat pediatric SJS/TEN, and I would assume that, you know, many of the principles are the same. The only thing that might be different is that, you know, I think there is a higher proportion of pediatric cases who are idiopathic or maybe even infection related. But I think the general principles of care in terms of supportive will probably be similar.
Yeah. And we certainly have the British Association of Dermatologists has very good pediatric specific guidelines for the management of SJS/TEN, which I would signpost to the listeners. So we've got time for one final question, I think. It's an easy one. Do you think that CRP can replace calcitonin as a marker of infection and sepsis, or do you think they're both better used together?
No, I don't think so. So we've looked at a variety of markers: race total white, ESR, CRP, and procalcitonin. And the only one that seemed to predict positive blood cultures were hypothermia and positive procalcitonin. Yeah.
Interesting. Okay. Yeah, which is an assay that's becoming more widely available. And certainly we were using it in my institution during the pandemic, COVID pandemic, for picking up bacterial pneumonias. Great. Well, HY, again, I thank you very, very sincerely for an absolutely masterful talk and for sharing your expertise so generously with us. It's clearly been greatly received by our audience and will be accessed by many more as a recording. So my sincere thanks, and I'm handing back to Christopher at the EADV for a few announcements.
Okay. Thanks, Sarah.
Hello, and we would like to say a special thank you to Associate Professor Lee for his wonderful presentation today and to Dr. Walsh for moderating the discussion. And on behalf of the EADV, thank you for joining us and sharing your thoughts and great questions with us. If you would like to re-watch this webcast on demand or share it with a colleague, it'll be temporarily available online on YouTube Live and permanently available for EADV members on the EADV e-learning platform. If you like the subject of today's webcast, as mentioned earlier, also check out the last week's episode of the Dermatology Podcast on the subject of Stevens-Johnson syndrome, moderated by our Dr. Walsh. The Dermatology Podcast is EADV's official podcast and is available on all major podcast platforms. Lastly, we are 2 weeks away from the EADV Spring Symposium. On the 6th and 7th of May, you can explore more than 30 topics across dermatology and venereology from over 100 speakers. For more information, including CME accreditation information, go to www.eadvsymposium2021.org. Again, thank you for joining us. See you again on May 5th, and have a pleasant day.